Basics of Medical Biochemistry. First edition, 2022. Chapter 23. Biochemistry of Hormones, Part 2 of 4. By Professor Dr. Muhammad Jawad. MBBS, Dow, M.Phil Philosophy, Ph.D., Dip M.E. 23.8 Posterior Pituitary Gland or Neuro hypothesis. The two hormones produced by the posterior pituitary gland are antidiuretic hormone, ADH, or vasopressin and oxytocin. The main function of ADH is to accelerate water absorption from urine in the kidney tubules into the blood, thereby decreasing urine secretion, whereas oxytocin stimulates the pregnant uterus to contract, may initiate labor, and causes glandular cells of the breast to release milk into ducts. These hormones are synthesized with their binding proteins in the supraoptic and paraventricular nuclei of the hypothalamus. After production in the hypothalamus, hormones pass along axons into the pituitary gland. These hormones are stored in Herring's bodies. These are the swelling of neurosecretory fibers found as secretory granules in the Neuro hypothesis. The secretion and release of posterior pituitary hormones are controlled by nervous stimulation. 3.8.1 Antidiuretic hormone, ADH, or vasopressin, it is secreted by the paraventricular nucleus in the hypothalamus. It is a nanopeptide hormone composed of 9 amino acids. 6 of these form a ring while the remaining 3 amino acids are found as a side chain. It is also known as arginine vasopressin, AVP, because of the presence of arginine and its vasopressor effect. It is packaged in secretory vesicles within the hypothalamic neurons. The hormone is with a carrier protein called neurophysin, and both are released upon hormone secretion. Regulation of ADH secretion. ADH release is stimulated by a plasma osmolality greater than 280 mosm/L, major stimuli, mediated through osmoreceptors in the hypothalamus, a fall in plasma volume, via baroreceptors in the left atrium, aortic arch, etc., stress, sleep and emotional factors. Other ADH stimulants include cholinergic stimulation, alpha-adrenergic stimulation, angiotensin II, prostaglandin E, opiates, nicotine, histamine, ether and phenobarbital. ADH secretion is inhibited by a fall in plasma osmolality, alcohol, beta-adrenergic stimulants, atrial natriuretic factor, ANF, and phenytoin. Mode of action. ADH binds to the specific receptors found on the cell membrane of the target tissue. There are 3 types of receptors to which ADH can bind. These are V1A in smooth muscle, liver, and brain, V1B in the anterior pituitary gland, V2 in kidney and V3 also in the anterior pituitary. All these receptors are attached to their respective G proteins. V1A and V1B use phosphatidylinositol and calcium as second messengers, while the V2 receptor uses CAMP as a second messenger. A diuretic is an agent that increases the rate of urine formation. Injection of small amounts of ADH into a person or animal results in antidiuresis or decreased formation of urine, and thus the hormone was named for this effect. Effects on the kidney. The single most important effect of ADH is to conserve body water by reducing the loss of water in the urine and promotes the reabsorption of water back into the circulation. In the absence of antidiuretic hormone, the collecting ducts are virtually impermeable to water, and it flows out as urine. The antidiuretic hormone stimulates water reabsorption by stimulating the insertion of water channels or aquaporins into the membranes of kidney tubules. These channels transport solute-free water through tubular cells and back into the blood, leading to a decrease in plasma osmolarity and an increase in the osmolarity of urine. Effects on CVS. ADH tends to raise blood pressure due to its vasoconstrictive action. Pulmonary and coronary arteries are also constricted. Bradycardia occurs due to increased reflex activity of arterial baroreceptors. It is often used to stop bleeding from esophageal varices as well as to treat hypovolemic shock, septic shock, and cardiac arrest. Effects on respiration. Respiratory rate is increased secondary to effects on CVS. There may be episodes of apnea. Effects on skin. There is significant pallor because even a small amount of ADH can cause severe constriction in skin vessels. Effects on smooth muscle. It causes smooth muscle contraction by increasing the cytosolic Ca2+ concentration. Effects on metabolism. ADH causes the increase in the secretion of ACTH, which then causes an increased release of cortisol from the adrenal cortex. The cortisol in turn causes hyperglycemia by the direct effect of ADH on hepatic glycogenolysis through V1A receptors. A lesser secondary effect that is mediated via V2 non-renal receptors is stimulation of synthesis and release of factor VIII and von Willebrand factor. 23.8.2 Diabetes insipidus. The most common disease of man and animals related to the antidiuretic hormone is diabetes insipidus. This condition can arise from either of two situations. Hypothalamic, central, diabetes insipidus results from a deficiency in the secretion of antidiuretic hormone from the posterior pituitary. Causes of this disease include head trauma, infections, or tumors involving the hypothalamus. Clinical features include polyuria, polydipsia, excessive thirst, nocturia or nocturnal enuresis, hypernatremic dehydration, anorexia, constipation, hyperthermia, raised metabolic rate and lack of sweating along with symptoms of the underlying cause. Possible complications of diabetes insipidus are hypernatremic dehydration and its neurological sequel like fits, growth retardation, and hydronephrosis, due to excessive urine output. Differential diagnosis. When symptoms of urinary frequency, enuresis, nocturia, and/or persistent thirst are present, the possibility of diabetes insipidus should be evaluated after excluding glucosuria by collecting 24-hour urine on an optimum fluid intake. If the urine output exceeds 50 ml/kg per day, 3,500 ml in a 70 kg male, and it may reach up to 20 liters, diabetes insipidus is confirmed and the patient should be evaluated further to determine the type. The urine is of very low specific gravity, which is usually less than 1.006. Treatment is by 4, intravenous, or SC, subcutaneous, injection of desmopressin, a synthetic analog. Other routes of administration like nasal inhalation or oral tablet can also be used. The doses required to control pituitary diabetes insipidus completely vary widely, depending on the patient and the route of administration. However, they usually range from 1 to 2 g qd or BID by injection, 10 to 20 g BID or TID by nasal spray, or 100 to 400 g BID or TID orally. The onset of action is rapid, ranging from as little as 15 minutes after injection to 60 minutes after oral administration. 2. Nephrogenic diabetes insipidus occurs when the kidney is unable to respond to antidiuretic hormone. About 10% of cases of diabetes insipidus are of this type. Most commonly, this results from some type of renal disease, but mutations in the ADH receptor gene or the gene encoding aquaporin 2 have also been demonstrated in affected humans. This disorder is treated by thiazide and other diuretics along with solute restriction. These drugs cause Na+ depletion, reduction in GFR, increased reabsorption of fluid in the proximal part of the nephron and ultimately reduction in dilution of urine. In order to categorize the various types of diabetes insipidus, the history alone may be sufficient if it reveals a likely antecedent such as pituitary surgery. However, if that type of indicator is absent, ambiguous, or misleading, then other approaches are needed. Except in the rare cases with hypertonic dehydration under basal conditions, differentiation should begin with a fluid deprivation test. 3.8.3 Syndrome of inappropriate ADH secretion, SIAD, or Syndrome of inappropriate antidiuresis, SIAD. It is the most frequent cause of hyponatremia, first described by Schwartz et al. In 1957 in 2 patients with bronchogenic carcinoma. It occurs when too much antidiuretic hormone, vasopressin, is released by the pituitary gland under certain inappropriate conditions, causing the body to retain fluid and lower the blood sodium level by dilution. It may be drug-induced, example chloropropamide, vincristine, cyclophosphamide, oxytocin, general anesthetics, narcotics, and tricyclic antidepressants etc., or due to diseases of the brain and head injuries. Ectopic ADH secretion is also seen when it is released from places other than the hypothalamus and posterior pituitary. For example, various malignancies like small cell carcinoma of the lung, lymphosarcoma, and Hodgkin's disease. It may also occur in tuberculosis, pneumonia, emphysema, chronic obstructive pulmonary disease, COPD, Guillain-Barré syndrome, acute intermittent porphyria, systemic lupus erythematosus, SLE, and severe renovascular hypertension, cardiac failure, and old age. Important signs and symptoms of SIAD are nausea, vomiting, muscle cramps, worsening mental status, including lethargy, weakness, irritability, agitation, confusion, combativeness, delirium, disorientation, hallucinations, and poor balance. Treatment is symptomatic and according to underlying cause plus control over water intake. 3.8.4 Oxytocin, oxy, rapid, tocose, labor. It is secreted mainly by the supraoptic nucleus in the hypothalamus. It is found in both sexes, but well-recognized physiological effects are seen only in women. It is a small peptide of 9 amino acids, nanopeptides, with a disulfide bridge joining the first amino acid to the sixth. It is synthesized in the cell bodies of hypothalamic neurons. Initially, it is produced as oxyphysin, which is then cleaved to oxytocin and neurophysin I. In some species, oxytocin predominates in the paraventricular nucleus, PVN. Extrahypothalamic sites include the gonads, adrenal cortex, thymus, uterus, and various parts of the brain. Mechanism of action: an oxytocin receptor has been identified on the myometrium and myoepithelial cells of the breast. After binding with the receptor, a specific G protein, GQ, is activated to set a signaling pathway through phospholipase C and Ca2+. Most of its effects occur through intracellular calcium release. It has the following important actions. 1. On the uterus, uterine contraction is the most prominent action of oxytocin. It induces labor in pregnant females. Muscle contraction of the uterus increased. An increase of oxytocin along with an increase in sensitivity of the myometrium to hormone may trigger labor. An increase in oxytocin receptors in the uterus is observed in late pregnancy. It may act as an endogenous signal for initiating labor. However, immunoneutralization of oxytocin does not block parturition. When labor contraction begins, the baby's head stretches the cervix of the uterus. Stretch receptors in the uterus send sensory impulses to the hypothalamus and posterior pituitary. Oxytocin is released and carried by the blood to the uterus where it strengthens uterine contractions. As contraction becomes more forceful, the resulting sensory impulse stimulates the secretion of more oxytocin. Oxytocin is present in circulation throughout pregnancy, but its levels increase only during the final stages of labor, not pregnancy. Prostaglandins and estrogens facilitate the responsiveness of the uterus. Progesterone inhibits the responsiveness of the uterus. Alcohol inhibits the secretion of oxytocin. 2. On mammary gland, it causes milk ejection after parturition by contraction of myoepithelial cells of the lactating breast. These cells are abundant around the nipple and areola of the breast. Sensory nerve endings localized in the nipple and areola of the breast are stimulated by suckling. Milk ejection starts within a minute after suckling. Secretion of oxytocin greatly increased during suckling. Deficiency of oxytocin secretion results in difficulty in nursing due to the inadequate milk ejection. 3. Actions in males and non-pregnant females. Oxytocin may play a role in the physiology of sexual responses by facilitating contractions of the smooth muscles of the uterus and vagina in women. Oxytocin may enhance both egg and sperm transport, thus promoting reproductive success. Oxytocin is released at the climax of human sexual response in both sexes. In females, it causes contractions of the non-pregnant uterus, while in males, it causes contractions of the vas deferens, increase in sperm transport. 4. On blood vessels, it causes marked vasodilation and fall in blood pressure along with tachycardia. 5. On corpus luteum, it causes degeneration of corpus luteum. 6. Other effects. Experiments have shown that oxytocin, along with estrogen, induces maternal behavior in virgin female rats. Oxytocin is present in high quantities in breast milk. It is also produced in detectable amounts in the brains of newly born mammals. Oxytocin is likely responsible for the reciprocal bonding of the offspring to their mother. It can inhibit CRF-stimulated ACTH secretion in males and also stimulate prolactin release from cultured rat anterior pituitary cells. 23.9 Pancreas, endocrine part. The pancreas is a leaf-like gland that lies behind the stomach and beneath the liver. It is a twin gland, i.e., composed of both endocrine tissues, secrete hormones, and exocrine tissues, secrete enzymes. Clusters of endocrine cells within the pancreas are called islets of Langerhans or pancreatic islets. It constitutes only about 1 to 2% of the total mass of the pancreas. It is composed of the following types of secretory cells. 1. Alpha cells, 20% of islets of Langerhans, secrete glucagon. Glucagon is catabolic as it mobilizes glucose, fatty acids, and amino acids from their respective stores into the bloodstream. It increases plasma glucose by stimulating hepatic glycogenolysis and gluconeogenesis. It increases lipolysis in adipose tissue. 2. Beta cells, 75%, secrete insulin. Insulin is an anabolic hormone that increases the storage of glucose, fatty acids, and amino acids. 3. Delta cells, 3 to 5%, secrete somatostatin, which inhibits the secretion of insulin, glucagon and pancreatic polypeptide. 4. F cells or pp, less than 1%, secrete a pancreatic polypeptide, which slows the absorption of food. 5. G cells, less than 1%, secrete gastrin. Figure 23.12 Types of cells in the islet of Langerhans of the pancreas. Source, Quora.com. 23.9.1 Insulin.
History. The discovery of insulin in 1922 marked a breakthrough in medicine and therapy for patients with diabetes. It is the first hormone to be isolated in pure form and the first protein to be sequenced, by Sanger. Long before the discovery of insulin, it was hypothesized that the pancreas secreted a substance that controls the carbohydrate metabolism. Frederick Banting, an orthopedic surgeon, had the idea of isolating pancreatic islet extracts by ligating the pancreatic duct of dogs, keeping them alive until the acini degenerated, leaving the islets for isolation. Eli Lilly began producing insulin from animal pancreas but fell short of the demand, and the potency varied up to 25% per lot. In 1978, the first recombinant DNA human insulin was prepared by David Goedel and his colleagues, of Genentech, by utilizing and combining the insulin chain A and chain B expressed in Escherichia coli. In 1982, the first insulin utilizing rDNA technology, Humulin registered R, rapid, and N, NPH, intermediate acting, were marketed. Structure of insulin. It is a polypeptide hormone composed of 51 amino acids arranged in 2 polypeptide chains, designated as A chain, 21 amino acids, and B chain, 30 amino acids. These two are linked together by 2 disulfide bridges. The first interchain disulfide link is found between cysteine residue found at position 7 of both chains, while the second interchain disulfide link is found between cysteine residue present at position 20 of A chain and 19 of B chain. The insulin molecule also contains an intrachain disulfide bridge between 2 cysteine amino acid residues found at position 6 and 11 of the A chain. The molecular mass of insulin is 5,808 and its isoelectric pH is 5.40. Although the amino acid sequence of insulin varies among species, certain segments of the molecule are highly conserved, including the positions of the 3 disulfide bonds, both ends of the A chain and the C-terminal residues of the B chain. These similarities in the amino acid sequence of insulin lead to a 3-dimensional conformation of insulin that is very similar among species, and insulin from one animal is very likely biologically active in other species. Indeed, pig insulin has been widely used to treat human patients. Insulin molecules tend to form dimers in solution due to hydrogen bonding between the C-termini of B chains. Additionally, in the presence of zinc ions, insulin dimers associate with hexamers.
Figure 23.13 Structure of insulin. Synthesis of insulin. The biosynthesis of insulin involves 2 inactive precursors, preproinsulin and proinsulin, which are sequentially cleaved to form the active hormone and the connecting, or C, peptide. The C peptide is essential for proper insulin folding. Because of its longer half-life in the plasma, its blood level is a good indicator of insulin production and secretion. The gene for the synthesis of insulin is found on the short arm of chromosome 11. Insulin is synthesized in significant quantities only in beta cells in the pancreas. Since it is a protein structure, it is synthesized like most other proteins via transcription and translation of DNA into mRNA and amino acid chains or polypeptide chains. Thereafter, the protein undergoes structural changes to achieve its final form. The insulin mRNA is translated as a single-chain precursor called preproinsulin made up of 109 amino acids, molecular mass 11,500. Thereafter, the removal of its signal peptide, 23 amino acids, during insertion into the endoplasmic reticulum generates proinsulin. The proinsulin is composed of 86 amino acids and its molecular mass is 9,000. Proinsulin is composed of three domains, an amino terminal B chain, a carboxyl terminal A chain and a connecting peptide in the middle known as the C peptide. In the endoplasmic reticulum, the proinsulin is exposed to several specific endopeptidases which excise the C peptide. The conversion of proinsulin to insulin occurs through the joint action of two types of proteases, one with trypsin-like endoprotease activity which cleaves after the dibasic residues pairs at each end of the C domain, and another with exopeptidase activity resembling that of carboxypeptidase B to remove the basic residues left after tryptic-like cleavage. This forms the mature form of insulin. Insulin and free C-peptide are packed in the Golgi bodies into secretory granules which accumulate in the cytoplasm. Figure 23.14 Synthesis of insulin.
Storage of insulin. It is stored in the cytosol in granules and released by exocytosis on the arrival of proper stimulus.
Mechanism of the release of insulin. When the beta cell is appropriately stimulated, insulin is secreted from the cell by exocytosis. The insulin then diffuses into small blood vessels of the pancreas. At the same time, C-peptide is also secreted into the blood but has no known biological activity. As insulin is rapidly broken down by the liver, thus must be secreted constantly. The human pancreas contains about 8 mg of insulin, 1 mg equals 28 units. The plasma basal values of insulin are 6 to 35 microunits, U/ml, which may rise to the peak value of 60 to 90 U/ml during meals. A healthy person secretes about 40 to 50 units of insulin daily. At high blood glucose levels, greater than 80 mg/dl, glucose enters the beta cell by glucose transporter 2, thus active metabolism of glucose in the cell raises intracellular ADP, which leads to the closing of K+ channels in the plasma membrane, depolarizing the membrane. In response to the change in membrane potential, voltage-gated Ca2+ channels in the plasma membrane open, allowing Ca2+ to flow into the cell. This raises the cytosolic Ca2+ enough to trigger insulin release by exocytosis. This is by activation of enzymes phospholipase C, which cleaves the membrane phospholipid phosphatidylinositol 4 into inositol 1 and diacylglycerol. The threshold for insulin release is approximately 80 mg glucose/dl. Certain amino acids, alanine, glycine, and arginine, act similar to glucose and cause the release of insulin by changing the membrane potential of beta cells. Acetylcholine triggers insulin release through phospholipase C and GIP acts via adenylyl cyclase. A protein-rich diet can stimulate insulin secretion, although the amount of insulin released during a high-protein meal is very much lower than that released by a high-carbohydrate meal. Figure 23.15 Mechanism of the release of insulin. Source: brain.cart.com. Synthesis and release of insulin are decreased when there is a scarcity of dietary fuels and during periods of stress, example trauma and infection, mediated primarily by epinephrine, the adrenal medulla. The release of epinephrine is controlled largely by the nervous system. Figure 23.16 Regulatory factors for insulin release. Source: Lippincot's Illustrated Review Biochemistry 7th edition. Table 23.5 Factors affecting the release of insulin. Increasing factors. Decreasing factors. High carbohydrate diet, hyperglycemia. High protein intake. High fat intake. Hormones of GIT, like gastric inhibitory peptide, gastrin, secretin, CCK, glucagon. Like peptide 1 etc., all these are collectively called incretins. Growth hormone. Glucagon. ACTH. Catecholamines via adrenergic receptors. Parasympathetic, vagus, stimulation. CAMP. Drugs, like sulfonylureas example tolbutamide. Glipizide, glyburide etc. Low carbohydrate diet, hypoglycemia. Low protein intake. Low fat intake. Hypokalemia. Catecholamines via adrenergic receptors. Drugs, like thiazide diuretics. Transport of insulin. When insulin is secreted into the blood, it circulates in an unbound form. It has a plasma half-life of about 6 minutes, so, blood insulin levels decrease rapidly once the rate of secretion slows. Glucose cannot diffuse passively into the cells. The only way for a cell to take up glucose is through facilitated diffusion with hexose transporters, GLUTs, that transport glucose across the plasma membrane down the concentration gradient. They are designated as GLUT1, GLUT2, GLUT3, etc., based on the order in which they were identified. In muscles and adipose tissue, insulin increases the content of facilitative glucose transporters, GLUT4, in the cell membrane, thus increasing the ability of these tissues to take up glucose. Figure 23.17 Glucose transport into the cells.
Table 23.6 Characteristics of glucose transport in various tissues.
Active transport. Facilitated transport. Insulin insensitive. Renal tubules. Intestinal epithelium. Choroid plexus. RBCs. WBCs. Eye lens. Liver. Cornea. Brain. Insulin sensitive. Skeletal muscle. Cardiac muscle. Adipose tissue. Table 23.7 Characteristics of glucose transporters, GLUT, glucose transporter, SGLT, sodium-dependent glucose transporter. Isoform. Tissue distribution. Features.
GLUT1.
Wide distribution, high concentrations.
In the brain, erythrocytes, fetal tissues and endothelial cells.
Na+ independent. Provide cells with their basal glucose requirements. Cancer cells express a high level of GLUT1, so
they can internalize more glucose, which is used as a source of energy for rapidly dividing cells. GLUT2.
Present in intestine, liver, and pancreas. Low affinity for glucose, it can transport only when there is glucose load in the body. Releases insulin by the movement of glucose into beta cells of the pancreas. Acts as a sensor for the release of insulin by the pancreas. Promotes uptake of glucose in liver cells, lowering blood glucose.
GLUT3.
Wide distribution, especially in
neurons and placenta.
Cancer cells express a high level of GLUT3, so they can internalize more glucose. Glucose is used as a source of energy for rapidly dividing cells.
GLUT4.
Adipose tissue, skeletal muscles and cardiac muscles. Insulin-responsive glucose transporter. Insulin promotes the uptake of glucose in the tissues by mobilizing the transporters to the cell surface. Whenever there is a high glucose concentration in the blood.
GLUT5.
Intestine at the luminal surface. Testicles and seminal vesicles. Mainly for the transport of fructose.
GLUT6.
Not known. Non-functional transporter, product of a pseudogene.
GLUT7.
Surface of endoplasmic reticulum. Liver. Transportation of glucose across the membrane of Endoplasmic reticulum. SGLT1. Kidney and intestine. For the absorption of glucose. In cases where SGLT1 is deficient, glucose is left unabsorbed and is excreted in feces. SGLT2. Kidney. For the absorption of glucose. If deficient, filtered glucose is not reabsorbed and is lost in the urine. Mechanism of action of insulin. Insulin binds to specific, high-affinity receptors in the cell membrane of many target tissues, example muscle and adipose tissue. The receptor has two types of subunits, the alpha subunits to which insulin binds, and the beta subunits, which span the membrane and protrude into the cytosol. The cytosolic portion of the beta subunit has tyrosine kinase activity. On binding of insulin, the tyrosine kinase phosphorylates tyrosine residues on the beta subunit, autophosphorylation, as well as on several other enzymes, proteins, within the cytosol. The metabolic activities of insulin are mediated through modulating the expression and activity of key enzymes in metabolism via the phosphatidylinositol 3 kinase, Pi3K, or IP3 pathway. Figure 23.18 Structure of insulin receptor. For insulin-related substrate, IRS, receptor proteins in cells have been described as IRS1 to IRS4. IRS1 is involved in many of the physiologic responses to insulin through complex mechanisms. Figure 23.19 Mechanism of action of insulin. The numbers of insulin receptors are increased during starvation but decreased in obesity and acromegaly. The affinity of insulin to its receptors is increased by glucocorticoids and decreased by adrenocortical insufficiency. Degradation and excretion of insulin. When insulin binds to its receptors, they aggregate in patches and are taken into the cell by receptor-mediated endocytosis. Eventually, the insulin receptor complexes enter lysosomes, where the receptors are broken down or recycled. Except for that portion of the insulin that combines with receptors in the target cells, the remainder is degraded by the enzyme insulinase mainly in the liver, to a lesser extent in the kidneys and muscles, and slightly in most other tissues. Hepatic glutathione insulin transhydrogenase causes the cleavage of disulfide bonds, then the individual A and B chains are rapidly degraded. This rapid removal from the plasma is important, because, at times, it is as important to turn off rapidly as to turn on the control functions of insulin. Figure 23.20 Degradation and excretion of insulin. Functions of insulin. Insulin is the major anabolic hormone of the body. Insulin has profound, diverse, and indispensable physiologic functions in growth and metabolism. The message that insulin carries to tissues is that glucose is plentiful and it can be used as an immediate fuel or can be converted to storage forms. At the same time, insulin acts to inhibit fuel mobilization. Insulin can act very rapidly, within seconds, example increased uptake of glucose, amino acids, and K+ in insulin-sensitive cells, or in minutes, example stimulation of glycogen and protein synthesis, or slowly, in hours to days, example lipogenesis. Effects of insulin on carbohydrate metabolism. Insulin promotes the utilization of glucose as fuel by stimulating its transport into muscle and adipose tissue. It promotes the storage of nutrients such as glycogen in the liver and muscle. Insulin stimulates glycogen synthesis via stimulation of enzyme glycogen synthase and inhibition of glycogen phosphorylase. The rate of glycolysis and HMP shunt is also increased. Effects of insulin on fat metabolism. Insulin promotes fat synthesis and storage. Insulin has several effects that lead to fat storage in adipose tissue. First, insulin increases the utilization of glucose by most of the body tissues, which automatically decreases the utilization of fat. Insulin also promotes fatty acid synthesis. This is especially true when more carbohydrates are ingested than can be used for immediate energy, thus providing the substrate for fat synthesis. Almost all this synthesis occurs in the liver cells and fatty acids are then transported from the liver by way of the blood lipoproteins to adipose cells to be stored. Lipoprotein lipase, fatty acid synthase and acetyl-CoA carboxylase are the main enzymes of fat metabolism stimulated by insulin. The transport of glucose into adipose cells mainly provides a substrate for the glycerol portion of the fat molecule. Therefore, in this indirect way, insulin promotes the deposition of fat in these cells. It causes extreme atherosclerosis, often leading to heart attacks, cerebral strokes, and other vascular accidents. Effects of insulin on growth and protein metabolism. Insulin promotes protein synthesis and storage. During the few hours after a meal, when excessive quantities of nutrients are available in the circulating blood, not only carbohydrates and fat but protein as well are stored in the tissues. It is achieved by the following actions of insulin. Insulin stimulates the transport of many of the amino acids into the cells. 2. Insulin increases the translation of messenger RNA, thus forming new proteins. It increases the synthesis of blood proteins by the liver. 3. Increase in the rate of transcription of selected DNA. 4. Insulin inhibits the catabolism of proteins, thus decreasing the rate of amino acid release from cells, especially from the muscle cells. Decrease in rate of gluconeogenesis in the liver. Effects on electrolytes. Insulin increases the permeability of many cells to potassium, magnesium, and phosphate ions. Role of insulin in the storage of fat in the adipose cells. Insulin has 2 other essential effects that are required for fat storage in adipose cells. Insulin inhibits the action of hormone-sensitive lipase. This is the enzyme that causes hydrolysis of the triglycerides already stored in the fat cells. 2. Insulin promotes glucose transport through the cell membrane into the fat cells. Some of this glucose is then used to synthesize minute amounts of fatty acids and a large quantity of glycerol phosphate. Insulin resistance. It is defined as a clinical state of decreased insulin biologic responses to a normal or higher insulin level. In a healthy person, serum insulin levels correspond to serum glucose levels. The relationship is inverse, i.e., the higher the insulin, the lower the glucose level. When both insulin and glucose levels are high, the situation is suggesting that glucose is resistant to insulin. Clinically, insulin resistance refers to decreased glucose uptake, utilization, and storage at normal or higher circulating insulin levels, ultimately resulting in glucose intolerance and hyperglycemia. Insulin resistance is the most common cause of diabetes in Western countries and is the most common clinical problem that involves glucose metabolism. More than 90% of type 2 diabetes is insulin resistant, and at least 25% of subjects with normal glucose tolerance may be insulin resistant but secrete sufficient insulin to overcome resistance. Insulin resistance is a key feature of the prediabetic metabolic syndrome, central obesity, hypertension, insulin resistance, and dyslipidemia. Mechanisms for insulin resistance are not clear but are likely multiple. About 50% of insulin resistance can be attributed to genetic factors and another 50% to lifestyle factors. 3.9.2 Glucagon. Glucagon is secreted by the alpha cells of the islets of Langerhans when the blood glucose concentration falls. Like insulin, glucagon is a polypeptide hormone. It is composed of a single chain of 29 amino acids, having a molecular mass of 3,485. It is also known as the hyperglycemic hormone. It has several functions that are opposite to those of insulin. The most important of these functions is to increase the blood glucose concentration, an effect that is exactly the opposite of insulin. Synthesis of glucagon. It is synthesized in the alpha cells of the islets of Langerhans. Its precursor is a large molecule of preproglucagon as a prohormone, encoded by the GCG gene. Glucagon is generated from the cleavage of preproglucagon by lysosomal peptidases like carboxypeptidase B and trypsin-like peptidases in alpha cells of pancreatic islet of Langerhans. Recently it has been demonstrated that glucagon is also synthesized outside the pancreas, most likely in the gut. It circulates without binding to carrier proteins. Its plasma half-life is 5 to 10 minutes. 25% of the glucagon is destroyed during passage through the liver. Glucagon is also degraded by the kidneys to some extent. Mechanism of action of glucagon. The main targets are liver, muscle, and adipose tissue. Binds to a GS-coupled receptor, resulting in increased CAMP and increased pKa activity. It acts through the activation of adenylate cyclase which results in the formation of CAMP. Also activates the IP3 pathway, which causes an increase in Ca2+ release. Regulation of glucagon secretion. Increased blood glucose inhibits glucagon secretion, whereas increased blood amino acids stimulate glucagon secretion. Increased levels of epinephrine and norepinephrine also stimulate the release of glucagon. High concentrations of amino acids, particularly arginine, occur in the blood after protein meals stimulate the secretion of glucagon. This is the same effect that amino acids have in stimulating insulin secretion. Thus, in this instance, the glucagon and insulin responses are not opposite. Exercise stimulates glucagon secretion. In exhaustive exercise, the blood concentration of glucagon often increases 4 to 5 folds. A beneficial effect of glucagon is that it can prevent a decrease in blood glucose levels. One of the factors that might increase glucagon secretion in exercise is increased circulating amino acids. Other factors such as beta-adrenergic stimulation of the islets of Langerhans may also play a role in the secretion of glucagon. Metabolic effects of glucagon. The main effect of glucagon is to maintain blood glucose levels during fasting. Following are the major effects of glucagon on glucose metabolism. I breakdown of liver glycogen, glycogenolysis. It is achieved by activation of glycogen phosphorylase, which cleaves off a glucose 1-phosphate molecule from glycogen. Inactivation of glycogen synthase by phosphorylation, less glycogen synthesis. Decreased glycolysis. Activation of lipases and ultimately increased breakdown of triglycerides. Inhibition of acetyl-CoA carboxylase and decrease in free fatty acid formation from acetyl-CoA. This results in more production of glucose and substrates for metabolism. 2. Increased gluconeogenesis in the liver. It is achieved by increase activity of phosphenolpyruvate carboxygenase, which stimulates gluconeogenesis. Increased protein breaks down and deamination of amino acids. Both of these effects greatly enhance the availability of glucose to the other organs of the body. The most dramatic effect of glucagon is its ability to cause glycogenolysis in the liver, which in turn increases the blood glucose concentration within minutes. Some other effects of glucagon are: it activates adipose cell lipase, to increase the quantities of available fatty acids. It inhibits the storage of triglycerides in the liver, this prevents the liver from removing fatty acids from the blood. Production of ketone bodies is promoted. It increases the blood flow in some tissues such as kidneys. Enhances bile secretion. Inhibits gastric acid secretion as well as intestinal motility. Increases both the rate and force of the heartbeat. Increases BMR, basal metabolic rate, and production of heat. This is called the calorigenic effect. Figure 23.21 Control of metabolism by insulin and glucagon. Table 23.8 Comparison between insulin and glucagon. Features: insulin, glucagon. Source: beta cells of islets of Langerhans, alpha cells of islets of Langerhans. Structure:
a polypeptide of 51 amino acids, arranged in 2 chains, A and B, linked together by 2 disulfides. Bridges: a single polypeptide chain of 29 amino acids.
Release stimulated by hyperglycemia. Amino acids, fatty acids, and ketones. Pancreatic and GI. Hormones, glucagon and gastrin. Medicines, sulfonylurea. Hypoglycemia. Amino acids. Stress. Epinephrine. Exercise. Release inhibited by hypoglycemia. Epinephrine. Somatostatin. Hyperglycemia. Insulin. Major effects: formation of macromolecules, storage of carbohydrates, fats, and proteins, and decreased blood glucose level, degradation of macromolecules to provide alternative fuels, and to increase blood glucose level.
Their function is to ensure that cells have a constant source of glucose, fatty acids, and amino acids for ATP generation and cellular maintenance.
23.9.3 Somatostatin, it is secreted by the delta cells of islets of Langerhans, having an extremely short half-life of 3 minutes. It is a short polypeptide containing only 14 amino acids. All matters related to food ingestion increase its secretion like increased blood glucose, increased fatty acids, increased amino acids, increased concentration of GI hormones. Actions of somatostatin, it has paracrine function locally within the islets of Langerhans where it depresses the secretion of both insulin and glucagon. It decreases the motility of the stomach, duodenum, and gallbladder. It decreases both secretion and absorption in the GIT. Its principal role is to extend the duration over which the food nutrients are absorbed into the blood by slowing its passage through the GIT. 23.9.4 Diabetes Mellitus. The word diabetes is derived from the Greek word siphon meaning pass through. Mellitus means sweet or honey. Diabetes mellitus is a clinical syndrome characterized by disturbance in carbohydrates, lipids, and proteins metabolism. The disease may result from a defect in insulin secretion, insulin action, resistance, or both, and it is characterized by hyperglycemia and glycosuria. In diabetes mellitus, glucose uptake by muscle and adipose cells is impaired because of the deficiency of insulin. It is a chronic syndrome characterized by a series of hormone-induced metabolic abnormalities. 2 long-term complications involving eyes, kidneys, nerves, blood vessels, and skin. 3. The lesions of the basement membrane, demonstrable by electron microscope. Types of diabetes mellitus. I type 1, insulin-dependent diabetes mellitus or IDDM. Type 1 diabetes most often manifests in childhood, hence also called juvenile-onset diabetes, and it is the result of autoimmune destruction of the beta cells of the pancreas. Individuals with certain human leukocyte antigens, HLA, have been shown to have a particularly high risk of developing type 1 diabetes. Type 1 can also occur in the elderly and is described as latent autoimmune diabetes in adults. 2. Type 2, non-insulin-dependent diabetes mellitus or NIDDM. It generally manifests after the age of 40 years and therefore has the obsolete name of adult-onset type diabetes. NIDDM is caused by either defective insulin secretion or improper insulin receptors. Table 23.9 Comparison of 2 types of diabetes mellitus. Type 1. Type 2. Synonym. Juvenile onset DM or IDDM. Adult onset DM or NIDDM. Age of onset. Usually, 25 years. At the age of teens. Usually, greater than 40 years. Prevalence. 10 to 20% of diagnosed diabetics. 80 to 90% of diagnosed diabetics. Genetics. 10% of first-degree relatives, 50% in identical twins. 20% of first-degree relatives, 90 to 100% occur in relatives. HLA association. Associated with HLA-D8, B15, DR3, and DR4. None. Plasma insulin level. Low or absent. Normal or high. Body weight. Thin and lean. Obese. Metabolism. Acute complication. Ketosis, no insulin. Hyperosmolar coma. Defect or deficiency. Beta cell destruction, no insulin formation. Beta cells unable to produce required quantity of insulin. Insulin resistance. Treatment. Insulin injections. By weight loss, exercise, or by hypoglycemic agent. Signs and symptoms of diabetes mellitus. 1. Polyuria, frequent urination. 2. Polydipsia, excessive thirst. 3. Polyphagia, excessive hunger. 4. Weight loss, usually there is no weight loss in type 2 diabetes. 5. Blurring of vision. 6. Weakness or fatigue. 7. Slow healing of cuts and wounds. 8. Numbness or tingling in the feet. 9. Skin infection. 10. Dry or itchy skin. Figure 23.22 Metabolic effects of low insulin/glucagon ratio. Diagnosis of diabetes mellitus, a raised blood glucose, hyperglycemia, can be diagnosed when an adult with a random blood glucose level of 200 mg/dl or more, on 2 occasions. Fasting value of about 126 mg/dl, on 2 occasions. 2 hours postprandial blood glucose level is more than 200 mg/dl in OGTT. Gestational GDM. It is a condition in which women without previously diagnosed diabetes exhibit high blood glucose levels during pregnancy. Gestational diabetes affects 3 to 10% of pregnancies. Hormones produced during pregnancy increase a woman's resistance to insulin, resulting in impaired glucose tolerance. Women with gestational diabetes are at increased risk of developing type 2 diabetes mellitus, or, very rarely, type 1 DM, after pregnancy. Impaired glucose tolerance, IGT. It is a transition phase between normal glucose tolerance and diabetes, also referred to as prediabetes. In IGT, the levels of blood glucose are between normal and diabetic. Weight loss and exercise may help people with IGT return their glucose levels to normal. Table 23.10 Reference range for blood glucose levels in mg/dl. Blood glucose sample. Normal. Impaired. Indication of diabetes. Fasting. 70-99. 100-125. Greater than or equal to 126. 2 hours postprandial. 140. 140-200. Greater than or equal to 200. 23.9.5 Oral glucose tolerance test. OGTT. Glucose tolerance means the capacity of the body to deal with ingested or injected glucose. OGTT measures the ability of the body to tolerate a standard dose of glucose. It is used to diagnose gestational DM and impaired glucose tolerance, IGT. Although it is more sensitive than fasting blood glucose determination, it may give false results because of stress and many other factors affecting the patient. OGTT is usually requested to investigate glycosuria. Urine specimen is tested for glucose, or when random or fasting blood glucose is suggestive but not diagnostic of diabetes. While performing OGTT, a fasting venous blood sample is collected. Glucose load, 0.75 g/kg. Body weight, of glucose in 250 to 300 ml water is drunk in 5 minutes. To reduce nausea, a few drops of lemon juice may be added to the water. Samples of blood and urine are collected at 30 minutes intervals for 2 hours. Results are graphed against time. The following points should be noted in normal subjects. 1. Fasting blood glucose at the start is within 70-100 mg/dl. 2. Blood glucose level reaches a maximum in about 1 hour. 3. After that, blood glucose begins to fall as a result of uptake and utilization by tissues. 4. After 2 hours, the normal level is restored. 5. In the course of OGTT, blood glucose never exceeds the renal threshold and no glucosuria is detected. In the diabetic individuals, 1. Fasting blood is elevated. 2. After glucose ingestion, blood glucose level will rise higher. 3. It may exceed the renal threshold and provoke glucosuria. Figure 23.23 Interpretation of oral glucose tolerance test, OGTT, Patient 1, normal, Patient 2, impaired glucose tolerance, Patient 3, diabetic. Exercise questions. MCQ 1. An obese individual is brought to the ER. The patient has been on starvation diet for 4 months, and has lost 30 kilograms while consuming only water and vitamin pills. Which of the following would be expected to be elevated in his blood? Acetate, acetoacetate, bicarbonate, glucose. MCQ 2. A student finished eating a well-balanced, 750 kilocalorie meal just 1 hour ago and has since been sitting quietly watching television. Which of the following substances cannot be elevated in this student's blood? Fatty acids, glucagon, glucose, insulin. MCQ 3. Which of the following cellular activities is decreased following exposure to physiologic concentrations of insulin? Formation of ADP, gluconeogenesis, glucose oxidation, lipogenesis. Please write answers in the comments. End of Part 2 of 4 of Chapter 23. Thank you.